we all do this. We look at those clinical characteristics and we're making immediate judgments about what the risk of a patient is. And one way that we do that is, for example, we might look at a patient and go, oh, you have nodes involved, you're high risk, right? The cancer's smart, it got to a lymph node, you're just, somebody we're worried about. But at a molecular level, when you're starting to look at the gene expression of these cancers, it turns out a quarter of those patients are actually low risk and very unlikely to benefit from extension of endocrine therapy. On the other end of the spectrum, there's lots of patients we look at and go, oh, the nodes aren't involved, it's a small tumor, you're going to do great. But hiding, lurking in that patient population at a molecular level is a quarter of patients who really have high-risk disease. So we risk misclassifying patients when we just kind of rely on those typical pathologic factors. So having a tool that analyzes these cancers at a molecular level can have real impact in terms of our treatment decision making. And so how does this play out in one of these trials? So here's some curves that have been published before in the IDEAL trial. On the left, you're looking at patients who had nodes involved, T2 tumors, yet had low scores on the BCI index. And what you're seeing is there was no difference for extending or having therapy for 7.5 years versus 10 years. The test just did not identify endocrine-sensitive tumors in that regard, despite the fact that these were high-risk clinical patients. On the other hand, on the left, here are some patients with T1 tumors, grade 1, BCI high. So these are patients we might be inclined to say, hey, you're in a good position, you don't need to extend therapy, yet there's nearly a 12% difference in this study for extending for the full 10 years versus 7.5 years of therapy. So these are contrary to our expectations for these patients. And we all do this. We look at the ER and we're like, oh, you got really great ER expression, you're going to be fine. You got really great PR expression. But if a biomarker really did correlate with success for extension of endocrine therapy, what you would expect is that the stronger the ER expression, the more likely of that benefit, right? And similarly for PR. But when you look at these on these curves, you're looking at the IDEAL trial, so 10 years versus, sorry, not the IDEAL trial, 10 years versus 5 years of study. And what you're seeing is a fixed difference between the two, suggesting that the test, this ER or PR, could not discriminate who is likely to benefit from extension of therapy. On the other hand, when you look at BCI, what you see is as that score continues to go up, as that ratio continues to increase, the gap between the two arms of extending versus not really does get bigger, suggesting that this biomarker can identify those patients as opposed to ER and PR that are likely to benefit from extension of endocrine therapy. So this has now been updated, and it's not shown here, but they looked at AR, ER ratio, a bunch of other factors, Ki-67 grade, et cetera, and none of those other factors are correlated with benefit of extension of endocrine therapy other than the BCI H/I index. People often say, well, I got a 21 gene recurrence score assay, I should be set, right? Like this should be enough. And what we're seeing is that with these other assays, that as the curves are continued to monitor, they continue to get wider and wider, and the predictive power, the tightness of the fit of that estimate is really lost. And you can see that playing out here. On the bottom, you see the recurrence score in the node negative, but also node negative, known to be HER2 negative patient. And really just the confidence intervals around those estimates for distance recurrences cross 1, they're wide, and really can't predict for who's going to be at risk for those late recurrences. However, when you look at BCI, you can see a clear shift into the range past the line of unity, suggesting that this biomarker can discern compared to the 21 gene recurrence assay. So how does this impact our patients? This is actually updated at this meeting, and when we have these results and we talk to our patients, roughly 40% of the time we're going to now counsel our patients differently than whatever our preconceived notion was. So this is actually slightly higher than that 25% I was just quoting you just a minute ago, and this is again being presented at this meeting. Based on this, it has been included in these guidelines, as Dr. Young just mentioned, and it's the only test that's recognized by both ASCO and NCCN, and likely to be other guidelines around the world soon, that can be pinned to this benefit of identifying patients with hormone receptor positive disease, early stage breast cancer, that are likely to benefit from extension of endocrine therapy.